On behalf of the American Heart Association, I would like to welcome you to the first session of today's Pain Management Summit. Oh, what a relief it is, pain management for our older adults. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. PDFs of the presentations are available in the Zoom events platform on the sessions page. Throughout today's presentation, you will have the opportunity to submit text questions for our speaker using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of the presentation as time allows. This presentation will be recorded and available within the coming weeks at heart.org/pain management. It is my pleasure to introduce our speaker for today, Dr. Marisa Galicia-Castillo. Dr. Galicia-Castillo is the director for the Glennon Center for Geriatrics and Gerontology at Eastern Virginia Medical School, where she completed her medical school training, internal medicine residency, and geriatrics fellowship, and joined the faculty there in 2001. She is currently the John Franklin Chair for Geriatrics and holds board certification in internal medicine, geriatrics, and hospice and palliative medicine. As part of the Geriatric Academic Career Award Program, she has earned a master's in education from Old Dominion University in 2005. Dr. Galicia-Castillo is the inaugural fellowship director for hospice and palliative medicine, as well as the medical director for several medical sites and programs. She has also published articles related to her research interests focused on geriatrics, palliative medicine, and medical education. Dr. Galicia-Castillo, the floor is yours.
Thank you so much. So good morning or good afternoon to everyone. And why don't we go ahead and start? So just some disclaimers here, and I have no disclosures. So I just want to start off with something a little bit interactive, just to know who is in our audience today. And I believe someone's going to help with the polling. What is your role? And I am not sure, where will I find the results? Will you all put that on for me? Okay, there we go. So we have quite a few nurses, nurse practitioners, and someone from therapy. We have a physician and others, 13 others. Okay, wonderful. Well, it's great to know who is out in the audience, and thank you so much. So what we're going to do in the next 40 minutes or so is talk about these three objectives. This is what we'd like to get through. First off, understand what the etiology and the impact of pain is in the older adult. We want to implement a thorough pain assessment in our population, our older adult population, and then examine both non-pharmacologic as well as pharmacologic management strategies for pain in our older adults. So as we talk about pain, we talk about older adults, it's always helpful to think about a patient as we're going through this. And we're going to talk about Mrs. Ramos. Mrs. Ramos is a 78-year-old lady, has a past medical history of heart failure with an ejection fraction of 25%, hypertension, diabetes, osteoarthritis, and she was admitted to the hospital for congestive heart failure exacerbation. Previous to this, she was actually very independent, able to do things for herself, a little bit slow, but was able to do them. And her daughter was living with her. During her hospitalization, she diuresed quite well and her symptoms improved, but she did not want to get out of bed. She was not having it. Therapy would come by and she politely declined. We find out later that she has such bad osteoarthritis in her knees that she was actually supposed to have a knee replacement surgery, but she refused that. And at home, she was using Tylenol, 650 milligrams every 6 hours as needed, and it ended up being 1 to 2 times a day. So as we go through this didactic let's keep Mrs. Ramos in mind. Our next poll, have you experienced pain? I'll give you all a minute to complete that poll. Okay, 100% said yes. Okay, it's probably the number one issue in medicine is pain. Everyone has experienced it at one point or another. So I think we all have a good feel as to what pain is. And we're going to talk about that with our first objective, understanding the etiology and the impact of pain, particularly in our older adults. So first I wanted to step back and talk about geriatrics, and it's medicine for older adults. And the main focus of geriatrics really is to optimize function and quality of life. We want to reduce morbidity and frailty in this population. So we want to really keep people as independent as possible and pain-free as possible. So there are quite a few challenges in this geriatric population. And part of it is because if you've seen one 80-year-old, you've seen one 80-year-old. They are such a heterogeneous population. And you can have a range from very healthy, active, independent, to someone who may be frail with cognitive impairment and is bedbound. So it's very important to understand what someone's function is as you are talking to your older adult to see what they're able to do. And as folks get older, there's just increased risk for both opioid and non-opioid therapy. And part of this is simply normal aging. There is reduced renal function and medication clearance, and that is over time. So if you look at their creatinine clearance, it does decrease, but it should still be within the normal range. But if you have a disease on top of that, perhaps diabetes or other kidney issues, it just exacerbates it that much more with normal aging. There's also an increased susceptibility to accumulation of medications, increased risk for drug-drug interactions, and there is a smaller therapeutic window. So we've got to look at those medications. We have to look at the comorbid medical conditions that may occur. And one other piece too that we need to keep in mind is there's some cognitive impairment, because certainly that will influence what we do and how we treat folks. So our population, I love the geriatrics population because they're just so unique, they're so fun, and they're such a, they're like I said, you've seen one 80-year-old, you've seen one 80-year-old. But again, there are some risks for changes in function, and that function, again, try to keep people as independent as possible, that can be exacerbated by pain. And if function is affected, that can also contribute to deterioration in overall health and independence. So continuing on with the theme of challenges of pain management, it may be underreported. Pain may be underreported, and part of that is some folks feel that as we get older, you'll experience pain, but that is not true. If there's pain, there's something causing it, and we need to identify what is going on. And we will talk a little bit about chronic pain and persistent pain. What is the difference between that and acute pain? And we're going to take this all together. So acute pain is less than, it's measured by time. So that's a pain that occurs for less than a month. Subacute pain between 1 and 3 months, and more than 3 months, that's when you consider pain to be chronic or persistent. And substance use disorder, just want to put that out there. It's beyond this lecture, but it is important to consider. So we will need to individualize and monitor closely for adverse effects. And the big geriatric mantra is start low, go slow, but use enough. And that people forget about that use enough, and we shouldn't withhold pain medicines. So when we're thinking about how best to manage pain, what's the most effective, what are we trying to do? It's a balancing act. We want pain relief, we want improved function, and we want to make sure we do that with as few side effects as possible. And in effectively managing pain, that decreases morbidity and mortality for our older adults. It does It does allow for faster recovery, shorter hospital stays, which in turn equals decreased healthcare costs. So etiology and impact, and here is these graphs represent the prevalence of persistent pain. And when you look at the community dwelling older adults versus nursing, those are in facilities and nursing homes, you can see even those in community who are out in the community, almost half, 25, a quarter to a half folks have pain, persistent pain, much higher in their nursing home residents. And when we think about pain, it's certainly a sensation in a part or parts of the body, but also by definition, it's unpleasant. And therefore, there's also that emotional experience, that emotional component we need to keep in mind. Now, persistent pain, that endures even though the pain signals, so pain signals continue to fire in the nervous system for, it could be weeks, it could be months, even years after that initial insult. And there are some people who suffer persistent pain, even in the absence of any past injury or evident body damage. So when we look at persistent pain, again, this is pain greater than 3 months. It affects at least 116 million US adults. And the estimated cost is almost 650 billion annually. And that's based on direct medical treatment costs and lost productivity. So what are some risk factors for persistent pain? Lower socioeconomic status, a vivid memory of childhood trauma, obesity, low level of physical fitness, overuse of joint and muscles, chronic illnesses, lack of social support, and abuse. Those are all potential risk factors in developing persistent pain. So our second objective is to really look at a thorough pain assessment in our population. And one of the things we have to do first is understand what are the different pain syndromes. And essentially there are 3. So there's nociceptive, and in terms of nociceptive, there's both somatic and visceral. There's neuropathic, and then there's a mixed or unspecified syndrome. And we're going to go through each one because it's important to understand what are the characteristics of these, how do we identify them, so that treatments are a little bit different depending on what type of pain syndrome you may have. So nociceptive, and this is somatic. This is the classic, you're hammering something and you hit your finger with a hammer. It's very well localized. Usually it's a constant pain. It's described as achy or stabbing or gnawing or throbbing. Those are some of the characteristics that are described for that type of pain, somatic pain. Now, what about the other nociceptive syndrome, which is visceral? And visceral, you think of internal organs. That's what I more internalized, and so therefore it's poorly localized in terms of describing pain. When you talk to your patients, it's hard for them to really identify what it is. They know there's something wrong. It's diffuse. There may be some referral to other sites, and it's described as intermittent or paroxysmal at times. Could be dull, colicky, squeezy. For some, it's deep or cramping. And there are other things that could be accompanied by it, including nausea, vomiting, or diaphoresis. Now, the second pain syndrome is neuropathic. And this is what I think of classically the pins and needles, but typically described as prolonged. It's usually constant, but there can be exacerbations of this. It's sharp, burning, prickling, the electric shock-like. And it's often associated with paresthesia, allodynia, hyperalgesia. Perhaps there's some other neurologic functions that may be abnormal. So those are our 3, that's our second one. And the third is this mixed or unspecified. And this one's a very tough one because it's very difficult to identify a pathologic process. And symptoms may seem to be out of proportion to the identified pathology. It's described as being widespread. There may be some stiffness that is associated with it, or weakness. So it's important to keep in mind the 3 different pain syndromes and what the qualities of the pain is, because that's going to influence how you're going to manage their pain. The other aspect in terms of pain assessment is what's the severity? And so getting a number from someone, everyone's going to have a different number, but you can compare it to themselves. So in talking about pain, one of the important questions to ask is, what pain is acceptable? So we can't assume 0 is going to be the goal for everyone. That would be great if we could, but we need to ask the individual person, if we can get your pain to what number, what would be the most acceptable? And then that's what we work towards, and hopefully we can get it even better than that. But again, from 0 to 10, 0 being no pain, 10 being the worst pain ever, and asking our patients this every day so you can see where they are. This is, again, the only objective measure, and it's going to be per individual. What do you do if your patient has cognitive impairment? And there have been some research that has reviewed 14 empirical research articles, and they found 2 different categories where nursing practice of pain assessment was less than optimal, and nursing practice of management, it varies. So the assessment and managing of pain from a nursing standpoint has been found to be less than optimal. And who do patients see the most? It's our nursing colleagues, and so they're the first defense. And so lack of initiation of pain assessment and use of pain assessment tools and understanding management is so important. And with folks who have cognitive impairment, specifically dementia, especially in a facility, we always think of PRN, right, as needed pain medications. But anecdotally, we almost see this as PRN being patient receives none for this particular population. They may not know to ask for it. They can't verbalize, so it makes it very difficult. There are some measures, for example, the pain assessment in advanced dementia, or pain AD, which you look at nonverbal things. So you're looking at breathing, you're looking at vocalization, we have negative vocalization, looking at facial expressions and body language, and are you able to console them? So using that assessment to determine where their pain is. You can't ask them, is it 0 to 10, but we can certainly assess them to see if they have any of these issues. Now, if pain is not managed, the issue becomes, it leads to more problems, can lead to depression, delirium, aggression, decreased mobility, and with decreased mobility, decreased daily functioning, and if they're in the hospital, prolonged hospital stays. So the third objective, which we're going to spend most of the time on, is to talk about both the non-pharmacologic and the pharmacologic management strategies for pain. So again, thinking of those 3 pain syndromes, nociceptive, both somatic and visceral, some non-pharmacologic measures are physical therapy and cognitive behavioral therapy. Same for neuropathic pain syndromes, you can use those from a non-pharmacologic standpoint. And then for mixed, you have both physical therapy, cognitive behavioral therapy, and also psychological therapy as well, which may be helpful in that particular syndrome. Other things that are non-pharmacologic, some physical therapy, some heat or cold therapy, massage, positioning, exercise. Some of these things are very helpful. And this is from another study that actually from our PM&R colleagues, which this is not specific to older adults, but it's helpful to look at for different options. So things such as acupuncture, acupressure, and the stars there show the evidence base for those different tools. Again, everyone's a little bit different, but it's important to know what different tools there are and what may be something that you could use, because again, a very heterogeneous population, something that works for one person may not work for another. So always think about the non-pharmacologic type things first, if possible. So the next step is, if the non-pharmacologics are not effective enough, that's when we start looking at medications. So besides pain relief, the goals are improved function and enhanced adherence with rehabilitation. Again, exercise is another area that can help with pain. If we can improve pain enough that people can do exercise or rehab, again, that will be very, very helpful. starting with non-systemic type of therapies or non-pharmacologic therapies first. Again, individualized. We have to think about what the risks and benefits are for each of our patients. And again, individualized, everyone is unique, and we have to monitor them closely. And I think I've said this several times, but again, start low, go slow, but you have got to use enough. Just because you start something, you can't just set it and forget it. You have to reevaluate and reassess. Other issues too, in terms of the I apologize, should have thought about talked more about the non-systemic therapies. Some examples, for example, if you have someone who has isolated pain, knee pain, they may respond pretty well to intra-articular corticosteroid injections, and that would help avoid systemic analgesics. Although convincing data supporting the use of these injections is lacking, but again, knowing what the different potential options may be. And then patients with myofascial pain, they can respond to local treatments such as massage, gentle stretching exercises, ultrasound, trigger point injections. And don't forget, there's also topical preparations that can be utilized, such as capsaicin or diclofenac gel or lidocaine patches. And so those can be effective as primary or as adjuvant therapy when you're treating neuropathic or myofascial pain syndromes. So another poll for you all, true or false? Opioids should never be used in the older adult to manage pain. I'll give you all a few minutes or a minute to participate. Wonderful. Everyone said false. Great. So let's talk about medications. So the World Health Organization pain ladder, this was developed some years ago, and it was really initially applied for managing cancer pain, but it's also helpful for acute and chronic non-cancer painful conditions, just because of the broad spectrum of diseases, such as degenerative disorders, musculoskeletal disease, neuropathic pain disorders, and other types of chronic pain. Now, the efficiency of the strategy is debatable and yet to be proven through large-scale studies, but nevertheless, it's still a simple palliative approach towards reducing morbidity due to pain in 70 to 80% of patients. Now, the choice of initial dose and rate of titration, again, has to be unique. It depends on the individual patient's physiology. That's why we always say, start low, go slow, but use enough. And so, as you can see here at the first step of the ladder, utilizing a non-opioid plus minus an adjuvant. If that persists and you go to the second stage, you're using opioids for mild to moderate pain. And then at the third step, opioids for moderate to severe pain, along with plus minus a non-opioid plus minus an adjuvant. So it's important to keep in mind, this is a great way of thinking about how to manage your patients. So first line non-opioid for us in the geriatrics world is acetaminophen. And what's very important to also keep in mind is acetaminophen can be found in other products, and there is a maximum dose of 4 grams in 24 hours. So there may be combination products that have acetaminophen and they're taking acetaminophen on top of that, that you have to really be careful of that. Now, in our geriatric population, because they are so heterogeneous, if you have folks that are frail, folks that are more debilitated, typically in my practice, I'll use 3 grams as my maximum dose. So, but Tylenol, acetaminophen is such a great medication to try. And sometimes you have to convince people. They may say, well, I've tried acetaminophen before and it doesn't do anything. Oftentimes what's going on is they take it at the time of pain. If you have someone who has some persistent pain, for example, from some arthritis, then using it on a schedule is much more helpful. And trying to get people to try it on a schedule can be challenging sometimes, but that's one of the best first lines to try. And if it works, it's great. Just using Tylenol on a regular basis. Sometimes you have to convince them. Now, non-steroidals, now you can use these, but use it very judiciously. There's so many potential risks with non-steroidals. There was the development of the COX-2 inhibitors that were supposed to help decrease that, and that decreased the GI bleeding risk by targeting a more selective receptor. But there's still the risk of renal complications and hypertension. That remains the same with all the other NSAIDs. And the degree to which longer-term GI toxicity is reduced is really not clear. Several studies have confirmed increased cardiovascular risk associated with COX-2 inhibitors, which is now believed to be a class effect. So NSAIDs, it's a tool in your toolbox, but if you use it very carefully and for a short period of time. Now, you can also try topicals because those are not systemic. Those are another options that you can use for our older folks. In terms of adjuvants, I'll just mention that there are tricyclic antidepressants. These are off-label. The biggest issue with these medications are really the risks. There's lots of risks that can occur with that. The gabapentinoids could be helpful, and corticosteroids also may be helpful as adjuvants. So we're going to talk about opioid therapy. Again, you see the mantra, start low, go slow, but use enough. And the biggest thing to look out for are the common risks. So number one, you need to prevent constipation. You want to do risk assessment for falls and monitor for any cognitive impairment. And universal precaution. So every patient should be assessed for risk factors related to the potentially problematic use of opioids. So this approach really tries to protect patients from the harm of substance abuse, and it helps primary care providers meet their legal and regulatory responsibilities. Various sources, including published guidelines and statements from state medical boards, those are all available to help clinicians assess and monitor patients with persistent pain to ensure that there's responsible opioid use. In our environment, people are afraid of opioids, and I just want to make sure people understand opioids are still a good tool. They just have to be used carefully. And if you're looking at specific opioids, look at morphine, oxycodone, and hydromorphone. In our older adults who have renal issues, you really want to avoid morphine due to the metabolite accumulation. So opioids are metabolized by the liver and then excreted by the kidney. So in kidney failure, you get these active metabolites of morphine, and that includes morphine 6-glucuronide and morphine 3-glucuronide. So 6 and 3, those can accumulate, and that places them at increased risk for prolonged sedation and possible neurotoxicity. So if you have someone who has a decreased creatinine clearance, you should really steer clear from morphine. In my clinical practice, I've found that oxycodone as an opioid seems to work better in terms of there's less cognitive issues as compared to some of the other ones. And hydromorphone has been shown to have fewer side effects also, again, with renal failure. And it's therefore the expert's first choice for that population. So if they have renal issues, move to hydromorphone. If they don't, at least in our clinical practice, we use oxycodone in our older adults. For opioid therapy, it's important to keep in mind that people do develop tolerance to respiratory depression, the fatigue and sedation that may occur, but something that they never gain tolerance is constipation. So anyone that you put on an opioid, you have to make sure you put them on a bowel regimen. And I remember one of my mentors once told me, if the hand that writes for the opioid needs to be the hand that writes for the bowel regimen, or it will be the hand that does the manual disimpaction. So always think about constipation in anyone that you're giving opioids for. And I do want to just make a comment on the respiratory depression. I think a lot of folks are afraid that they'll stop their patient from breathing, but it has to be very large doses of opioids to cause respiratory depression. And before respiratory depression occurs, you're going to get sedation first. So again, start low, go slow, but use enough. So we talked about medicines that we should use, and these are a few that we should avoid. So meperidine, not really effective in doses that are commonly used. There's a higher risk for neurotoxicity that includes delirium than compared to other opioids. And there's just other safer alternatives that are available. As I mentioned with the NSAIDs, there's the increased risk of gastrointestinal bleeding or peptic ulcer, especially in the high-risk groups. That includes those over 75, people that are taking oral or parenteral corticosteroids, if they're on anticoagulants or antiplatelets. You could use a proton pump inhibitor or misoprostol to help reduce that, but it doesn't eliminate the risk. And upper gastrointestinal ulcers, gross bleeding, or perforation caused by NSAIDs occur in about 1% of patients treated for 3 to 6 months, and in 2 to 4% of patients treated for a year. And these trends continue with longer duration of use. Also, you need to look out for blood pressure issues and the kidney injury. Risks are all dose related. And the increased risk of gastrointestinal bleeding or peptic ulcer disease and acute kidney injury in older adults is highest with indomethacin. That's higher compared to the other NSAIDs, and it can also have adverse CNS effects. So if all the NSAIDs, indomethacin is the most in terms of adverse effects. And then skeletal muscle relaxants, most are really poorly tolerated by older adults, and there are anticholinergic adverse effects, sedation, increased risk of fractures, effectiveness at dosages tolerated by older adults really is quite questionable. So you really want to avoid these medicines. Now, NSAIDs you can use on a short period, but in general, try to avoid these medicines in our older population. So one way to look at this, it's based on the World Health Organization ladder. It started with some Tylenol first. You could try some topical analgesics to very specific areas, non-systemically, then systemically, using Tylenol 500 to 1,000 milligrams every 6 hours. Again, trying to use a schedule, and you need to be careful that we don't go over the maximum amount. Notice the dotted lines, NSAIDs, if you can, use it for less than a week. So ibuprofen, for example, 200 milligrams 3 times a day for a short period of time. You also have the options of the TCAs, gabapentinoids, and corticosteroids as adjuvants. And then if there's moderate to severe pain, that's when you start adding the opioids. So you may need to add it earlier if the other measures don't work. So we're going back to Mrs. Ramos. Again, she diuresed well, but just really wouldn't get out of bed. You find out she's got pretty bad knee osteoarthritis, so bad that she should be getting a knee replacement, which she refuses. So what do we do for Mrs. Ramos? Oh, well, what first? I'm going to ask you all. Which of the following should we not use chronically for older adults? And we'll put that polling question up. So vast majority of you said NSAIDs. Yes, you want to avoid NSAIDs for chronic use in our older patients. Excellent. So for Mrs. Ramos, we got physical therapy to evaluate her. And in the meantime, utilizing acetaminophen, started off with 650 every 8 hours and went up to 1,000 every 8 hours. We avoided NSAIDs. And even with the acetaminophen, she was still having some breakthrough pain. So then added oxycodone 5 milligrams every 4 hours as needed. And she did pretty well. So just to summarize, and to bring back these take-home points, first off, an older adult is more than just an older person. They are such a heterogeneous population. You have to treat folks on an individual basis. What works for one may not work for another. So again, being very, very clear and very personalized and individualized in their pain management. Pain is often undertreated in the older adult, and this affects lots of things. It affects their function, quality of life, physical acute, but often, physically, you can have acute pain, but often there's persistent pain with an exacerbation or a new injury. It's important for you to understand the different types of pain, because the type of pain helps guide the type of pain management you are going to utilize, whether it's non-pharmacologic or pharmacologic. And lastly, opioids are an important tool to providing pain relief. And it's essential to understand how to use opioids because there are many barriers. We need to be able to look at each distinct person and background and individualize treatment for every person. And here are some references, and I'm happy to take any questions.
Thank you, Dr. Galicia Castillo, for your presentation. It is my pleasure to now introduce our Q&A moderator for this session, Dr. John Sun. Dr. Sun is an interventional pain management specialist at Augusta University Health Medical College of Georgia. He is board certified in pain medicine and anesthesiology and has been working with the American Heart Association on our pain, hypertension, and CVD management initiative as part of our learning collaborative. Thank you for leading the Q&A for this session, Dr. Sun.
Thank you, Christine. Also, thank you, Dr. Galicia Castillo. It's a great lecture, and also I think it's a very important topic. Yeah, we all know that working with geriatric patient always is challenging. Yeah, as an anesthesiologist, I always review. We'll do pre-op evaluation just before the surgery to see any comorbidities. But for me, I think the first important thing is to see the age, because aging always is associated with comorbidities and some organ dysfunctions. So now we get some questions for you, Dr. Galicia Castillo. The first question is that the one audience wants you to, can you please address the Medicare LCD limitation, which means there's a Medicare local coverage determination limitations. For example, for the patient who had like lumbar spondylosis, they only can receive 2 facet joint injections every year. Then the insurance may deny for further treatment. So do you have any other plan regarding the pain control?
Oh, that's a tough one, because it's those are great options to use, but when fiscally, financially, it's not covered, it's very difficult. You know, I think as we had talked about, using acetaminophen on a scheduled basis may be helpful. I mean, it would be great if they could continue to pay. Medicare, I think we would have to then talk to our legislatures to help us change those things. But if we're not able to do that, I think using the acetaminophen on a scheduled basis, physical therapy, some of the measures that we just talked about in the lecture today, that is unfortunate, though. I was not aware of that.
Yeah. Okay. Yeah, let's move to the next question. I think this question is from the audience. Ask for his or her mother, actually. That, yeah, I think the audience mother maybe has some chronic situation, but her daughter only want to give some non-opioid stuff and avoid to do any opioid. But the pain really bothers and limit the activities. So what do you suggest?
Yeah, CBD is the up and coming thing. The only issues, or some of the major issues with CBD, is that it's not truly regulated. So you're not sure what you're actually getting. I'm just curious why they want to avoid the opioids, because that is actually a pretty good drug when it's used carefully, as we talked about, starting at a very low dose. And typically, if there's concerns, I will use 5 to 10 milligrams of oxycodone every 4 hours. If there's concerns, I've gone down to 2.5 milligrams, and then to kind of go up from that, making sure they've got a bowel regimen and that type of thing. So I would recommend trying to use an opioid, again, at lower dose, unless there's something else that is going on we're just not aware of here. And again, don't let them get constipated. That's a big issue. Again, with CBD, I just worry because it's not regulated at this time. So you may buy something from the store and it may not have what it actually says on the bottle. That's one of the concerns I would have.
Yeah. Okay. Then the next question is, can Suboxone be used in the old adults?
Personally, I have not used Suboxone, but again, I think as you go through the different options that that you're using, and you're not able to achieve the goal of improving pain, I think it's still a great option. It's another tool. I think that's the biggest thing, making sure we know what all the tools are in our toolbox. I just personally have not used that in this population. And I think every region may be a little bit different. We don't use a lot of Suboxone in our area.
Okay, I think the topic is really interesting. So we receive a lot of questions. Okay, we have some more. Do we know that, our older patients are sometimes very opinionated. So what happens when they insist on using the NSAIDs more?
That is a great question, and it's challenging. I think the best that we can do is continue to educate with NSAIDs, just that risk of kidney issues, especially if they have heart failure, the exacerbation of heart failure, the bleeding. It's really tough, especially if somebody's been on it for 20 years or 30 years. Who are we to say, well, they've been using it? But as we get older, there are the normal aging, things that occur with normal aging, which includes, as we talked about, our creatinine clearance will decrease over time, but it stays normal. It's just on the lower end. So all you need is that one extra hit, and that puts you into renal failure. So it's really tough. It's all about education, and trying to just help people understand why we want to avoid that, because there's just more potential. There are other medications that have less side effects.
Yes. And the next question, I think, not from me, but I love the next question. So this question is: there is a big push for use of non-pharmacological interventions for pain. Is there any research that supports one intervention over another?
Yes, I think I had in one of my slides, it talks about some of the non-pharmacologic type things. And Dr. Sun, you're probably much more attuned to this than I am, but I believe acupuncture has been shown to be very effective in the research. Some of the other things, the TENS units, some of the very interesting things, virtual reality. I'm not sure how, I've never seen that used, but it's been in the literature. Mindfulness training. I'm not sure which one is better than the others, but certainly there are other options that are out there that are non-pharmacologic that could be used. The only other thing would be, what is covered by your insurance. That might be an issue, but definitely there are those other non-pharmacologic options are there.
Yeah, I agree. Yeah, just people respond differently. Sometimes we have to do procedure until when we see the responses. Okay, we have another question for you. If an older adult complains of pain and they just receive this scheduled pain medication like tramadol, should you give a PRN right away or wait until the scheduled tramadol works?
So I didn't mention it in the talk, but I try to avoid tramadol. That's just my personal practice. So tramadol is kind of a quasi opioid. Typically, I will do scheduled Tylenol first before using any kind of opioid-ish kind of medications. Now, depending on where they are, I mean, if I'm taking care of someone who is at end of life, then I'm pretty aggressive with giving more opioids if they need it every hour, every 2 hours. Typically, I wait until the scheduled pain medicine is at its maximum. And so again, I don't use tramadol very much, but typically with an opioid within an hour to 2 hours, if they need something else, you can give an extra dose at that time. You don't have to wait. I'm not sure if that answered that question because it was specifically regarding tramadol.
Yeah, but I think the principle applies to all medications. That yeah. And so when do you feel it's necessary to refer a patient to the pain management?
I think if you've tried all sorts of medications, and I don't do any interventional, but there are other interventional, Dr. Sun, you could probably speak to that, options that could be helpful. I think once you've gotten past opioids and you've ramped it up quite a bit, I think that's a good time to start talking to a pain management specialist. Unfortunately, in our area, we don't have very many of those folks. So hopefully in your areas, you have someone that you can refer to. But the interventional, there are a number of interventional opportunities that might be more helpful for them.
Yeah, so yeah, I think as a pain physician, we do both medication and the interventional procedures. I just say, we call this as multimodal management, really based on how to balance the benefits and risks. Doesn't mean the procedure can bring more risks than the medication. So we should always be careful with the side effects from the medications. Yeah. And so I have another question for you, Dr. Castillo. Thinks that opioids are an important tool to provide pain relief, but now during the current opioid crisis, a lot of physicians are not willing to write opioids. So what do you think about?
That's so unfortunate. I think the pendulum has just gone from one end to the other, where, I mean, I was in practice when pain, do you remember when pain was the 5th vital sign? And so it's quite unfortunate because opioids are very good tools. It's just like anything else. You can use something to the detriment, but you can also use it for the benefit. And I think it's education again. It is hard, and at least in our area, there's several primary care that they won't prescribe opioids. And I think of my patient in long-term care. She's 9 years old, horrible bilateral knee arthritis. She gets along fine. She gets her oxycodone 10 milligrams twice a day. That's all she needs. But you get all these warnings, and it's very scary. But I'm comfortable because I know my patient. I know what her function is, and it's again education. It's utilizing the tools, starting low, going slow, documentation. It's just unfortunate that opioids have gotten a bad rap, and it's really gone the other way. Even for patients that I've taken care of in hospice, sometimes it's hard to get opioids for them. I mean, it doesn't make any sense. But you're right, that's the world we live in. So what do? I think we try to educate.
Yes, I agree. And I think opioid still is a medication. Just like other medications, it does come with side effects with other problems, I think just start low and titrate slow and monitor closely still is a tool for us to manage the pain. Actually, I think the updated CDC guideline just recommend to use this type of medication just individualized.
Yeah.
Doesn't like before say, okay, don't give
Mhm.
such kind of dose or just a lot of restrictions on that. So I think that still, that's opioid still is a medication to treat different type of pain. Yeah. Okay, actually, that's all the questions for you today.
Okay,
Thank you so much.
well, thank you, Dr.
Great topic,
Sun.
yeah.
Thank you, Dr. Galicia Castillo and Dr. Sun for this great presentation and Q&A. And thank you to our audience for your participation. A feedback survey will pop up in the lobby after you exit this session. We will have the recording of this session posted on heart.org/pain management in a few weeks. Please be sure to check out that website for current and future educational opportunities or to join our mailing list. Coming up next at 1 p.m. Central, we have Exploring the Roles of the Inpatient Analgesic Stewardship Pharmacist, a vital member of the Interdisciplinary Pain Management Team. Thank you very much for attending this summit. We will see you shortly.